Good evening, surgeons. We will just wait a few minutes for everyone to join in. Please tell me when you are here. Hi Serge, welcome. Give everyone a minute. Is anyone else joining us? Just let us know on WhatsApp. Okay, I've decided to cover a fairly common pathology that as general surgeons we are expected to know in a lot of detail. These types of patients usually relegated to the most junior member of the surgical team, and unfortunately this results in less than optimal care of these conditions. And I decided to cover this topic because it's actually very important, and as a general surgeon you should have a very in-depth understanding of perianal complaints. It's one of the bread and butter topics. 1 second, Serge is having some trouble. Let me just send the link on the group. Just try this link, guys. Just tell me, let me know if the volume is okay via WhatsApp, please, on the group or to me directly. The link is the same for the live stream every week. The recording, the link changes, but the live stream is the same link every week. So you guys should probably save it as a shortcut somewhere on your phone or on your PC. And then when it is 7 p.m. on a Wednesday and you know there's a live stream, you can just click on the link and you can go directly to it. Anyway, getting back to our topic, practical approach to perianal complaints. We are going to look at a number of different pathologies, and the problem is that unfortunately patients and a lot of junior doctors, a lot of GPs just classify any perianal pathology as piles. Right? It could be hemorrhoid, it could be a fissure in anal, fistula in anal, it could be pruritus anal, anal cancer, even rectal cancer, rectal prolapse, vaginal prolapse. And unfortunately junior doctors tend not to want to examine the patient because either they themselves are shy or they don't want to stick a finger in the patient's bum, right? Which unfortunately results in the old adage, if you don't put your finger in it, you put your foot in it. And these junior doctors very frequently continue this sort of approach to perianal pathology, and they don't like to examine patients, and unfortunately this is how all these conditions just become labeled as piles. So you'll get a referral in SOPD patient with piles, please help. Signature of the doctor. So it's very important that we have a detailed understanding of the perianal pathology, and we should try and educate as many people as possible, our interns, our nurses, who will subsequently go out and become community service doctors, professional registered nurses at a clinic, right? And they shouldn't be labeling things as just piles. The photograph in this image shows an obvious thrombosed external hemorrhoid, which is a very painful condition, and we will cover that in this talk as well. Okay, good. Serge is able to join. Just let me know what the volume is like. I'm using a slightly different platform today. I'm running it off a PC as opposed to a Mac. I'm using a new microphone and some fancy video adapters, as you can see. So just let me know if it appears clearly and you can see everything clearly and the sound is good. Okay, now this is a fairly complex diagram, hand-drawn diagram. I always encourage my students, that's both undergrads and postgrads, to try and draw things. Even if you're in an exam, you can take a minute or two to actually sketch out a diagram like this. This, I must admit, is a fairly complex shaded diagram, but a simple schematic or line drawing diagram will help you as well. And this just puts all the perianal pathology on one page and gives you an idea of the anatomical position, etc. For example, fissure in ano is associated with a sentinel pile. On examination, you may only see the sentinel pile, and the patient will not allow you to do a PR examination. The thrombosed external hemorrhoid, which we saw on the previous file, is on the anoderm or anal skin. Because of this, it has somatic innervation and it's excruciatingly painful. Everything above the dentate line, as you know, is mucosal and has autonomic innervation and therefore is painless. That's why internal hemorrhoids above the dentate line, above the anoderm, are relatively painless pathologies. Perianal abscesses are associated with fistulous tracts and anal crypts, anal glands. You know, the columns of Morgagni. At the base of the columns, there are little anal valves. There are anal glands which secrete a little bit of mucus. The mucus is secreted through the anal crypt, and the physiological reason for this is that the stool requires some lubrication, and this allows the stool to pass out more easily. Unfortunately, these anal glands and crypts can easily become occluded, obstructed, and you know that as soon as there's obstruction, infection sets in, and the anal gland is actually the source of the classic anal perianal abscess, and there's always a fistulous tract associated with it. Right, we're going to go into a little bit more detail on the fistulous tracts. Perianal abscesses can be different in position. Submucous abscess, this is a huge ischiorectal or ischioanal abscess, and the other normal physiological pathology that we just need to be aware of is the external anal sphincter, the ischiorectal space, levator ani muscles, pelvirectal space above the levator ani muscles, and the intraperitoneal part of the rectum, which is above the peritoneal reflection, which is usually well away from this area, but it can be involved in a high fistulous tract. Guys, if there's any questions, please feel free at any time to just post them on WhatsApp. Okay, moving on to the next slide, we're going into a little bit more detail about the fissure in ano. This is a very common perianal pathology. It is associated with hard stool, straining, lack of hydration or adequate water in the diet, lack of adequate fiber in the diet. And what actually happens is, in straining and trying to pass a hard stool, the patient actually causes a tear in the anal mucosa or anoderm, right? And because it's the anoderm that's involved, as I mentioned earlier, this involves somatic innervation, and it's excruciatingly painful. Hemorrhoids, on the other hand, are higher up above the dentate line. Somatic innervation, autonomic innervation. Autonomic innervation does not carry pain fibers; it only carries stretch, and hemorrhoids are typically therefore painless. The fissure results in the patient being very uncomfortable. This patient typically will come into the consulting room, and when you ask them to sit down, they refuse because it's too painful to sit down. When you try to examine them, they'll actually jump out or off the examination couch, and they are not willing to allow you to even go anywhere, to even inspect the perianal area, let alone do a PR examination. There's a differentiation between an acute fissure in ano and a chronic fissure in ano. Both of these, typically more the chronic, is associated with a sentinel pile. The sentinel pile is really just a skin tag which points to the position of the fissure in ano. And even on inspection, without doing a PR, you may be able to see this sentinel pile, which gives you an indication that there's a fissure in ano, which may not be visible, and the patient will not going to allow you to palpate. For the acute fissure, you can offer the patient a trial of Anusol, Movicol, and high fiber diet, and the topical application of glycerol trinitrate cream. Now, for some reason, we do not have glycerol trinitrate cream available as a pre-prepared or pre-mixed preparation. I'm not really sure why this is, but if you ask your hospital pharmacy, they can easily take KY jelly or Remicade gel and mix it with TNT tablets, the angina tablets that patients use under the tongue. They grind the tablet, mix it into the Remicade jelly, and they can give this to the patient to apply. How does one distinguish a chronic from a acute fissure? Just sorry, 1 second, Riemann. I have no idea why you cannot connect. We're doing everything the same. We are streaming on WhatsApp, on YouTube, so you shouldn't really have a problem. It may be your internet connection. I apologize for that. If you cannot watch us live, then you should be able to watch the recording later on. I'll send the link out later. Okay, so we're talking about distinguishing between an acute and chronic fissure. The chronic fissure, one is typically able to see fibers of the internal anal sphincter running transversely across the base of the fissure, and this is what makes it a chronic fissure. Also, the duration, the symptoms present for more than 6 weeks suggests a chronicity. Right, in this image, there are a couple of other conditions that are shown as well, which we should be aware of. Fibrous polyp, villus tumors in the mucosa, and this is a pedunculated polyp, which you may see on insertion of an anoscope, or you may palpate on PR examination. One should be aware of these. Right, now we all know that the treatment for a fissure, chronic fissure in ano, is a lateral sphincterotomy done under general anesthetic. In the operative lectures that I've done towards the middle, I think, of last year, I have got videos of all these procedures. You are welcome to go back and have a look. We are not going to have time to look at any videos today. Okay, in the treatment of fissure in ano, it's important to actually avoid laxatives. Laxatives such as Senocot and a lot of the commercially available products actually cause a major problem, because patients use them for years, if not decades, and they find that the longer they use these purgatives or laxatives, the more they require. And I've actually seen elderly patients whose mucosa is basically tattooed, pigmented with this dark melanosis coli, which actually turns the mucosa from a pink color to a black color. Right? It's quite dramatic to see, and it's usually irreversible. And unfortunately, it indicates a patient who has been abusing laxatives over many years. And unfortunately, in this case, many of these instances, the patients end up with a lazy bowel syndrome, whereby the colonic peristalsis is weak, and they actually exacerbate the condition. The only thing one can really do is to encourage them to stop using the laxatives, try and put them onto something safer like Movicol or Normicol, which are simple bulk forming agents. These can be used every day for the rest of their life. And if they present, for example, with fecal impaction, then one might need to take them to theatre for an EUA and disimpact the rectum. But this is a major problem, and as far as possible, you should always be encouraging patients to avoid laxative abuse. I would say avoid laxative use altogether. Unfortunately, liquid paraffin and the glycerine suppositories that we have available in the state are not ideal. It is possible to get Movicol. Movicol is definitely available in the tertiary and quaternary centers, and it is possible to actually motivate with your pharmacist and get this product for your patients in state practice. In private practice, obviously, it's a simple matter of writing a script and the patient collects it from the pharmacy. High fiber diet, there's been a lot of talk about this. Some people don't believe in high fiber diets anymore. I still would recommend this to patients. I personally still try and take a high fiber diet myself. Bran, muesli, yogurt, 2 liters of water a day. In our hot weather in Durban and Richards Bay, I'd actually suggest even more than 2 liters a day. Lots of fresh fruit and vegetables are also recommended. Okay, these products, like I mentioned, are completely safe. They contain bulk forming agents that basically draw water into the rectal or the colonic lumen, and in so doing they create a bulk, a large stool, and this allows the patient to have a soft large stool, which is more comfortable for the patient and avoids tears to the anal mucosa. Right, now there's a number of different types of anal fistulas. Basically, the fistulas all originate from an infected anal gland, which I've already alluded to, and depending on the path of least resistance, this inflammatory process progresses in various directions, and you can have intersphincteric fistulae, high fistulae, fistulae that are tracking all the way above the levator ani, intersphincteric, subcutaneous, and these have a number of treatment options. The idea is to try and locate the internal and the external openings if they are indeed present, avoid rough insertion of a probe into the external opening, because it's possible to actually create or cause a false passage, and this is not going to allow you to treat the fistula properly. So the surgical intervention can be quite extensive. It requires either a fistulotomy or fistulectomy, but the idea is to find the granulomatous, chronic granulomatous tissue that is lining the fistula and to scrape that away, or to excise the entire fistula and send it for histology. Unfortunately, this results in fairly extensive damage to the perianal area. We need to take cognizance of Goodsell's law. This is an old law which still holds true today, and basically says that any fistulae which are anterior, if we look at the clock face, but anterior to the 3 and 9 o'clock position, horizontal line. This is in the lithotomy position, not a prone jackknife position. So anterior to the patient, anterior aspect of the patient's body. These fistulae tend to be radial, right? They all point to the midline of the anal canal. The posterior fistulae, however, tend to all tract towards the 6 o'clock position, the posterior midline. And every rule has an exception. Anterior fistulae, which are more than 3 centimeters from the anal verge, can in fact track all the way posteriorly, and they are not radial in nature. Okay, so that's a little bit about fistulae in anal. Probably the safest treatment is the conservative treatment, where you put in a seton. You can use silk, you can use a infant feeding tube, and unfortunately the patient's got to go home with this uncomfortable device. It's unpleasant for the patient, there's a lot of complaints, however it does in fact work. Okay, Riemann is linked up, well done. So the seton needs to be placed preferably in theatre, sterile conditions under anesthesia, because any manipulation of the perianal area without adequate anesthesia can result in a vasovagal attack, which can be very dangerous for the patient. Therefore, the seton should be placed in theatre in sterile conditions under anesthesia. However, the subsequent adjustments of the seton can be done in the outpatient setting. It's a matter of tightening the silk or the infant feeding tube, and slowly with time what happens is that it actually cuts through, like you see this probe inserted here. If a seton was there, slowly tightening it, it actually cuts through that tissue, surprisingly without causing too much of damage to the anal sphincters. Okay. Any questions, guys? Please send them via WhatsApp. Okay, going on to perianal abscesses. Right, perianal abscesses can look relatively small. This initially seems to be isolated to the right buttock, but you can see that on opening it's very extensive. The surgeon's entire finger fits in there, and eventually it required extensive debridement, and this would be a typical ischioanal fossa abscess, which basically tracks. There's the anal canal here. This tracks posterior, and there's like a U-shaped cavity. This entire area would have been full of pus, and the skin was also necrotic, so this entire area was debrided thoroughly. Surprisingly, wounds like this can actually heal by secondary intention. It's very difficult to skin graft these wounds. It's not always necessary to do a defunctioning colostomy. Yes, if it's difficult to manage the patient, you can certainly consider that, but wounds like this can actually heal by secondary intention. Unfortunately, there will be significant scarring in this area. The diagrams on the right are just nice schematics showing the different types of fistulae, complex fistulae, external intrasphincteric, transsphincteric, intersphincteric. And the upper picture just shows the different positions of the possible anal abscess, including pelvirectal, which is above the levator ani, submucous abscess, ischiorectal abscess, which we've seen just now in the photograph, And then you can even get a very superficial subcutaneous perianal abscess, and it's even possible to get a retrorectal abscess, which can not be accessed from the anal approach. Okay, any questions? Please feel free. Okay, moving on to hemorrhoids. We've already spoken about external hemorrhoids, and these are to be distinguished from internal hemorrhoids, which are typically painless. The definitive procedure is the open hemorrhoidectomy, the classic Milligan-Morgan operation, which was designed more than 80 years ago, results in a cloverleaf excision pattern in the perianal area. It's extremely painful, and however, it does work if done properly. There are other operations available: Longo's stapled hemorrhoidectomy, or hemorrhoidopexy as it's called, which more recently has fallen into disfavor. Apparently there's a high incidence of recurrence, but conceptually it makes a lot of sense, and the procedure is done above the dentate line, which results in relatively low pain post-op. Okay, the internal hemorrhoid is this large collection of veins forming the hemorrhoidal plexus. It's a physiologically normal structure, and it helps to seal the anal canal. Unfortunately, with straining, hard stool, it's actually results in the hemorrhoids being prolapsed. Later on, I'm going to ask you about grading of hemorrhoids, so please start thinking about it now. These other conditions, all of these conditions, hemorrhoids, thrombosed external hemorrhoids, as well as anal skin tags, are all incorrectly called hemorrhoids or piles. Right. Okay, rectal prolapse. This tends to occur in older patients, female patients who have had multiple vaginal deliveries, large babies, where the mother has had no option but to push if they were not able to get a Caesar or get to theatre in time, and the passage of the fetus through the perineum causes excessive stretching, and the entire area gets weakened. This can result in a combination of vaginal prolapse as well in a female patient, and the rectal prolapse on its own may be in a female or a male patient. And the different types are prolapse where only the rectal mucosa is involved, and lower down we see more of a procedentia, which involves all layers of bowel, and you can even get small bowel herniating into the sac adjacent to the hernia, the prolapsed rectum. Okay, these procedures can be treated. The rectal mucosa can be rectal mucosal prolapse can be treated by resection of all the redundant mucosa, and then you simply suture the proximal to the distal mucosa. Stapled hemorrhoidectomy device is very useful for repairing this. The procedentia is more complicated. It requires rectopexy, typically with a mesh where we put in, this can be done laparoscopically. Mesh is tacked to the sacrum and sutured to the rectum, the distal rectum, and as the fibrosis occurs, it tends to hold the rectum in place. Okay, anal warts. These are very common. We see it in children. They're thought to be caused by a human papilloma virus, which is transmitted from person to person by direct contact. HPV is considered a sexually transmitted disease. Please be aware of this. Patients do not have to engage in anal intercourse to develop anal condylomata. Right? Also, children with HPV warts, it's not, you have to exclude it on history. You must possibly send a social worker to look into it, but it does not mean that the children were necessarily raped. It is possible that a child can actually pick up HPV infection by vertical transmission during delivery, normal vaginal delivery, and they then present with very early onset of HPV anal condylomata. And please be aware not to label or suggest that the patient had been raped or sexually abused. It's not always the case. Yes, you must consider it and question the family in detail, but do not label it as rape or sexual abuse. And similarly, male patients presenting with anal condylomata are not necessarily gay or engaging in anal intercourse. Right? Please be aware of this. Treatment of anal warts. Podophyllin, I wanted to highlight this. Right? We tend to dish out podophyllin in outpatients departments. I've heard that family medicine departments just give patients podophyllin to apply to perianal warts. This should not be done. Podophyllin should actually be applied by a doctor or a nurse. It should not be applied by the patient. The problem with podophyllin is it's very effective. It burns these warts, and it unfortunately also burns the surrounding skin. The idea is to actually surround or cover the normal skin with petroleum jelly or Vaseline, and then carefully apply the podophyllin. And it should be in contact only for 30 to 40 minutes, after which it should actually be removed or washed away. Right, so please do not dispense podophyllin to patients. And if you come across this occurring elsewhere in your hospital, please advise your doctors to avoid this practice. Right, what do we use to treat anal warts? Podophyllin you can use it, it's not a problem. In private practice, it is actually available at Albert Luthuli. Does anyone know what the medication, specialized medication is that we can use to treat anal warts? Please answer on WhatsApp. Anyone? Anyone heard of Aldara? Okay, this is one of the best treatments available. It's got a difficult name, imiquimod, which can be used in adults and children over the age of 12. It is an immune response modifier. Well done, Ismail. It is safe. You can apply it to normal skin without it causing any damage, and it is very effective. Okay, unfortunately it's quite expensive. It is available in the state and tertiary hospitals, and this is the stuff that you should be using. Okay, so please once again motivate your pharmacist and get this stuff for your patients. Okay, pilonidal disease does not really fall under the spectrum of perianal pathology, but I've mentioned it because doctors get very confused. They see a pilonidal abscess and they refer it to you as a perianal abscess because it's relatively near to the anus, but we know that it's more in the natal cleft, as you can see in this picture. Anal canal is somewhere down there, so this cannot be considered to be a perianal abscess. Unfortunately, there's a lot of junior doctors, nurses who have not been explained the difference between a pilonidal abscess and a perianal abscess, and they would inappropriately label this as a perianal abscess. There have been cases of patients being sent to theatre for IND of a perianal abscess because the intern looked at the referral letter, sent the patient to theatre. The registrar has the patient in the registrar unfortunately didn't get to see the patient, has the patient in the lithotomy position. The pilonidal abscess is completely invisible in this position because the patient's actually lying on it, and the patient goes to theatre and comes out of theatre, and the registrar says there's no bloody perianal abscess here. Meanwhile, there was a pilonidal abscess that needed to be attended to. So please guys, always examine your patients, preferably in the casualty area or in the ward before they come to theatre. I do know that you guys get busy and that's not always possible. So preferably examine the patient, talk to the patient, get a history before they are put under anesthetic, even if it's in the recovery room. Okay, so please don't make this mistake of taking a pilonidal abscess to theatre and trying to drain it in the lithotomy position and then yelling at the intern because there was no abscess found. Okay, pruritus ani is a very common condition, especially in our hot weather in the east coast of South Africa. The problem is that the perianal area gets very itchy. The patient feels very conscious because they feel that their body odor is bad, and they then try and clean the area excessively. They put all sorts of powders and deodorants, and this actually makes everything worse. It's a very difficult condition to treat. The patient should be reassured. Try and avoid washing, scrubbing, putting deodorants or powders in the perianal area. What they can possibly do is put a always pad or sanitary pad, even for male patient, in the perianal area to just try and absorb the excess moisture and keep that area dry. But it's quite a difficult problem to treat in our setting. Okay, anal cancer. Right, we know this is associated with the condyloma acuminata. Guys, you've got to be aware that patients would present with extensive condyloma acuminata. We need to biopsy it. We need to ensure that there's no malignancy developing here. And one of the biggest problems I've seen is that patients do the biopsy, doctors do the biopsy, and no one follows up the result. Right? If you do a histology, it is your responsibility to follow up that result. You should actually, each one of you should have a little book. Every time you're in SOPD or in theatre, you do a biopsy, make a note of the name, the date, patient's hospital number, date of birth, clear identification of the patient, and you should follow up the histology yourself. Because what happens is that you move on to another block, the patient then comes to SOPD, the intern sees the patient, oh yes, the wound looks fine, very nice, give you some Panado and go home, and they don't see that intra-op a biopsy was done. Right? This is a huge problem. We see a lot of malignant pathology being missed in this way, not only in the anal canal, but everywhere in the body. Right? So please have a plan to ensure that your histology is checked. Someone does it, someone checks it, mark it clearly in the, not only in the op notes. In the op notes some frequently get lost. Make a note in the inpatient note, make a note in the outpatient note, tell the patient, make a note on the patient's booking slip, please check histology. Right? It's relatively easy. The nursing staff will see that. They will hopefully go and look for the histology, pull it out, and put to the patient to put in the file so that it's there when you see the patient. Okay, but it's not the nurse's responsibility, it's the surgeon's responsibility. Okay, please encourage your colleagues. As general surgeons, we all do PR exams, well, I hope we do. But please encourage your colleagues not to avoid PR examinations. Right? What I said earlier, if you don't put your finger in it, you'll be putting your foot in it. Okay, and these are the patients that are missed, and they present 6 months later with a now huge foul-smelling fungating lesion, which requires extensive treatment and is very debilitating to the patient. Okay, here's a pop quiz. Grading of hemorrhoids. We grade them 1 to 4. If each person can give one grade, what's grade 1, grade 2, grade 3, and grade 4. Quickly post it on WhatsApp. Let's see who knows the grading of hemorrhoids. Anyone? Yes, good. Kalangu says the grade 4 is irreducible. They will not go back into the anal canal. Grade 3. Grade 3, anyone? Grade 2, grade 1? Okay, grade 3, manually reducible, yes. Grade 2, it's spontaneous. That's right, so it prolapses, a patient can feel it, they can palpate it, and they say that it goes back slowly on its own without them having to do anything. Grade 3, it prolapses and it won't go back on its own. They have to force it or push it back with their finger digitally. And grade 4, it's irreducible. Grade 1, of course, is internal non-protruding. Very good. Right, that's all done. Guys, you need to know this. You would very likely be seeing lots of hemorrhoid patients in SOPD. Okay, there's the answers. No prolapse. Grade 2 retains spontaneously. Manual reduction and remains prolapse to irreducible. Right, and then you can include a grade 5 if you want to call it that. It's not classically described, but strangulated hemorrhoids is a complication of grade 4 where the anal sphincter causes the portion of the hemorrhoid that's external to become very big and swollen, and this now becomes excruciatingly painful. Furthermore, they can start bleeding quite heavily, and because of that venous congestion, these patients can actually have a massive hemorrhage from a strangulated, prolapsed hemorrhoid. Okay, so be aware of that as well. Okay, I've got a little summary which just helps you distinguish all these different conditions. I will post this up onto the teachable.com website. I'm not going to run through this now. It's just for you to read and understand and put it into perspective. You don't need to memorize these kind of things by now. You ought to have a fairly good understanding of perianal pathology, and this is just to help you clarify the differences. Okay, so it's available on the video, and I'll also upload it to YouTube. Alright, we end with this slide where we must encourage our patients not to strain on the toilet stool seat, because this is what leads to a lot of perianal pathology. It contributes to hemorrhoids, it contributes to fissure and ano, and it can even contribute to fistula and ano, and ultimately perianal abscess and fistula formation. Okay, that brings us to the end of the lecture. Thanks very much, guys. Let me just close that up. I just want to show you that the videos, we've got lots and lots of videos available on YouTube. Right, if any of you want a link, right, the videos are also up on the teachable.com website. This is the teachable.com website. Each of you should have a login and password. If you don't, please let me know. Right, we've got lots of stuff here. Please make use of it. Right, guys, I have the live streams here as well. Right, live streams from May last year. If not every week, every alternate week, we've got from May all the way up to March. Right, we've got lots of useful stuff. I've also started uploading the Saturday seminars. If anyone needs to look at them, the UKZN seminars are excellent. Right, now, guys, I'm able to see who's logging in and who's using this, right? We've got people who have been here recently, a week ago, right? And then we've got people who never look at it, Okay, so I'm not trying to name and shame anyone. I just went over that very quickly. But guys, it doesn't appear that you are using all these resources. Unfortunately, those that are using it, I'm not going to take this down. It'll always be available, but it takes a lot of my time to actually do all this stuff, and if people are not going to use it, like the OSCE questions, you've seen I haven't posted anything in a while because I haven't had a very good response. So if the interest peters out and people are not participating, I need to get feedback from you guys. How do I get feedback? From questions. You guys are welcome to contact me directly. You're welcome to call me. If I can't take the call, I will call you back. Send me a WhatsApp, send me an email, right? I need an engagement to see if you guys are actually participating. I know that it obviously takes up time. It's not always possible, but if I don't see that engagement, then I can only assume that I'm not producing stuff that is relevant or useful to you guys, in which case I'm not going to do it. There's no point in me wasting my time thinking that I'm producing something useful when it's actually not useful. We've got a question from Marwan. Can we classify hemorrhoids as internal and external, thrombosed and non-thrombosed? Okay, that's a good question. The internal and external hemorrhoids, we do classify them as internal and external. The diagram that I showed you just now refers entirely to internal hemorrhoids. The classification of grades 1 to 4 plus minus grade 5, and the thrombosis is only relevant to external hemorrhoids. So I wouldn't use it as a general classification. What I'd rather do is start by separating them into internal and external, and then the external is subdivided into they typically become thrombosed, right? So it's typically a thrombosed external hemorrhoid. We don't often pick up non-thrombosed external hemorrhoids because the patients don't have any pain and they wouldn't often come in with that complaint. Marwan, I hope I've answered your question. Any question that I answer that you're not sure of, that you need more clarity on, once again, I'm available for you to contact. Okay, so guys, we've got Teachable, we've got YouTube, we've got YouTube Recorded, we've got YouTube live streams, we've got all the stuff that I've done uploaded to Teachable, which you should be able to access. You can watch it online at your own leisure. Right, you can see there's lots and lots and lots of stuff available here. Pleasure, Marwan. And then the other thing we have is the e-questions that I've been posting. So I just want to show you the last e-question I posted was in March. It's just uploading. Only one person has responded, right? The first response is always my model answer. So we've got only one person that's responded there, right? Let's go back a bit. Seventh of March. Okay, we've got 4 responses there. That's great. That's 3 actual people that have responded, and my model answer making it 4, which is not that great, I guess. So yeah, I'm not going to bother with e-questions for now. Please, can people contact me, tell me what I can do, if you'll need me to focus on a particular area. I really don't know. I'm just not getting much feedback. So yeah, that brings us to the end of today's topic. I will upload the video, the lecture, and the little handout to Teachable later on. I will also send out the link to the YouTube recording so you can watch this. Ravi had sent his apologies, for example. He is not able to attend. Okay, thanks very much, guys. All the best.